I am Sabine Roman. I am MD PhD. I am pleased to present our work realized at Northwestern University in Chicago. This work aimed to evaluate the inter-observer agreement in high-resolution esophageal pressure topography interpretation using the Chicago classification. The Chicago classification is a classification of esophageal motility disorder in high-resolution manometry. This classification is based on the application of new metrics to quantify abnormalities in sphincteric and peristaltic function. A good reproducibility is essential to use this classification in clinical practice. Therefore, our aims were to evaluate the inter-observer agreement for the calculation and the application of the metrics used to formulate the Chicago classification. We randomly selected 30 esophageal pressure topography studies among 2,000 consecutive studies realized from January 2007 to May 2010 at Northwestern University. All DCPT studies were realized with the same equipment and the same protocol. The studies were reviewed independently by 3 different observers, a senior clinician, a junior clinician, and a non-clinician skilled in esophageal motility. The junior and the senior clinician attended to the same training session with an expert. Each observer characterized all the swallow with the different EPT metrics, that is the IRP to assess EGG relaxation, the DCI to assess the vigor of the contraction, the distal latency, and the CAV to assess the propagation of the contraction. The peristaltic integrity was also assessed at 20 mm per mercury isobaric control. Then, each swallow was characterized as normal, failed, hypertensive, weak, or rapidly propagated. Finally, a motility disorder diagnosis was given by each observer for each study according to the Chicago classification. This diagnosis was compared to the diagnosis of the expert. Our results show that the inter-observer agreement for abnormal measurement was almost perfect or substantial for all the measurements between the junior clinician and the senior clinician, and between the senior clinician and the non-clinician. The inter-observer agreement for the swallow characterization was substantial between the junior and the senior clinician, and moderate between the senior clinician and the non-clinician. The majority of the discrepancies was misclassification between normal and weak peristalsis, and between weak peristalsis and failed peristalsis. Finally, the diagnosis of motility disorder was in accordance with the diagnosis of the expert for 93% of the cases for the senior clinician, 83% of the cases for the junior clinician, and 73% of the cases for the non-clinician. Once again, all the disagreements were for the distinction between the normal and the weak peristalsis, and between the weak and the frequent failed peristalsis. So the main conclusion of this study is that the inter-observer agreement for the different EPT metrics is substantial or almost perfect with a minimum training. So the discrepancies in applying these metrics to establish diagnosis with the Chicago classification concern the selection between normal, weak, and absent peristalsis. Weak and absent peristalsis are often non-clinical significance. Therefore, the Chicago classification may be applied accurately in clinical practice after minimal training. I thank you for your attention and will be pleased to answer to your question.